Let's talk. Your health and wellness podcast.
Good evening, everyone, and welcome to a special edition of Let's Talk. I'm Dr. Avron Urison, and it's great to have you all on the podcast with us this evening. And tonight we're focusing on women's health, from early adulthood through to menopause and beyond. We've got a great panel lined up for you. So, as usual, we've got one of our health and wellness and fitness experts, Mike Huse. Mike, welcome. Nice to have you on the show and the podcast. And we are very honored this evening to welcome one of South Africa's leading gynecology experts, Dr. Trudy Smith. Trudy, welcome, and nice having you joining us as well.
Thank you.
Look forward to the conversation. A very hot topic. No pun intended on the menopause side of things, but a hot topic, and something we're going to enjoy chatting. So let's go straight into it. And I think the first part is obviously setting the stage, right? So in starting with the basics. Trudy, can you, and I think what would be useful for our listeners is for you to explain, because we're going to go before and we're going to look at before, during, and after menopause. But I think as a start would be great for you to explain what is menopause and when women typically start experiencing the symptoms.
So the word menopause actually means your last menstrual period ever in your life. That's what menopause means. So we often clump menopause into a syndrome or a problem, but it's really your last menstrual period. And the average age is around about 50, but it can be 47 to 52 or 53. And it really often follows family lines. So if your mom had her last menstrual period, for instance, very early, like when she was 42, she had premature menopause, you are actually at risk of premature menopause yourself. But if your mom had her last menstrual period when she was 55 or 56, you might be one of those outliers who has her last menstrual period then. But with this word menopause, there's the premenopause, so before your last menstrual period, and then there is postmenopause, after your last menstrual period. And in fact, scientifically, we've now come up with a thing called the straw classification. And the straw classification is good because what it says is that you are reproductive, you can reproduce, have children, and then you go through the early perimenopause, then the late perimenopause, then you have your final menstrual period, then you have early postmenopause and late postmenopause, because all those stages have different symptoms and different problems.
Right.
Or maybe no problems at all.
Exactly. So where's the change come? I mean, we know there's a lot of information, I presume misinformation. Hopefully we can tackle that this evening as well to an extent. But historically then, what were the thoughts? How does the new classification differ to the old one?
So how that helps us is that, often we use surrogate markers or markers to say we are menopausal, but there are subtle changes that happen. So men make sperm for life. Men can reproduce for life. Their testosterone might decline, but in many men, the testosterone doesn't. And men make sperm until they die. Whereas women, we are born with a finite number of follicles in our ovaries. And those follicles are responsible for our hormones, for our estrogen, our progesterone, and in fact, our testosterone as well. And as we age, our follicles decline. That's why if we're going to make a baby, in fact, the best time to make a baby is probably in your 20s, because that is when your ovaries are at their freshest and their youngest. And after 35, our follicular or our ovarian function starts to decline. And certainly after 40, our fertility declines, our follicles decline, and then our hormones start changing and becoming less functional like they were in our reproductive ages. So were we designed to live this long? It's difficult to say, but I can tell you that other mammals can, their ovaries work forever. The only people who, or mammals that theoretically get menopause are ourselves and whales, actually, which is quite
Sure.
interesting. I'm not too sure how they found that out, but yeah.
Yes. No, that is interesting. But I suppose also what you said, so historically we just had, I suppose, women that thought, well, they're fine, then they have menopause, and then it's post-menopause. But I think what you're elucidating for us is that there's a phase before menopause, and we're going to go into that, that different categories.
For sure. So, there's a big buzz now because now I'm getting 30-year-olds who come in and tell me, I think I'm premenopausal. But in fact, not necessarily, and especially if you're on a contraceptive.
Right. So let's move into we'll talk about premenopausal first. And maybe we can just go start on the health side, sort of the health side that you are seeing, Mark, and you may want to give your comments or thoughts in terms of what you see in terms of women premenopause and sort of the health and fitness side of things, and then we can ask Trudy for input on that.
Cool. Yeah. I mean, again, I'll be the first one here to say this is not necessarily my exact field of expertise. Obviously, we deal with range of ages of people in our gyms, including women and men, and we see that they get more challenging as men and women get older to maintain health. So I think that if we're saying what's the best thing to do premenopausal, obviously I think the old adage of prevention is better than cure kind of rings true. So if you're making efforts now to, let's say, do resistance training, because one of the markers of menopause is dropping in estrogen, obviously that decreases bone density. So, just doing things like resistance training earlier on, building a little bit more muscle mass, will obviously offset the negative impacts of that once you go through menopause. That to me would be the most beneficial thing for a woman to start doing, because I think, again, as we've discussed in many podcasts, women are kind of pushed away from resistance training. They're pushed more towards cardio, and that's not a bad thing, because as I know, and Dr. Trudy can correct me, is, to my knowledge, menopause does have an increased marker risk for cardiovascular conditions. So, getting cardio in and doing resistance training as a combination will help offset the bone density loss and muscle mass loss, and obviously improve the cardiovascular health. But it goes hand in hand, and it's something that you can get on very early in life. And if you set a good tone for it, then once you get to that point that you are just naturally, unfortunately, dropping estrogen, you're going to be in a much better position. Whereas if you've never trained and all of this happens, it becomes slightly harder, not impossible, of course, to start your resistance training, to get into some good cardiovascular training. And I think at the same time, you've also got to be sympathetic to yourself. Again, obviously can't talk on the going through menopause and the hormonal fluctuations, but recovery is decreased as estrogen drops off and bone density drops off. So you've got to just be kind to yourself and understand that your recovery is going to take a little bit longer. If you have been someone that's been training for years and now you're going through menopause, things are a little bit harder, and just be a little bit easy with yourself, because I think understanding that you can't overcome something that is natural by being upset with it and upset with yourself that you're no longer able to do what you might have been able to do 5-6 years ago, just does allow yourself to feel a little bit better about the situation and stay consistent.
Yeah. Trudy, in your experience with women in premenopause, you found that they're doing the required exercise, sort of what Mark is alluding to.
Oh, absolutely. I mean, I agree with Mike. What I say to patients, you want to enter a situation in your best health. So when you're going to go into menopause, which we are all going to do as women, whether we like it or not, we are all going to become menopausal if we're going to age. So you want maximum bone health before you get there, because you don't want to enter there with poor bone health and then get a decline. And then it's really hard to exercise and to have strength training when you never did it before. So you should be all your life exercising, obviously, even adolescents. Adolescents should be entering into their reproductive years with good bone health. And then we need to, particularly in our 40s, early 40s, 30s, be doing strength training together with cardio so that your bone health is maximum. You want a bone density that's really good when you get into menopause. So I would 100% agree that you need both of those two things.
Right. And cardio as well, right?
Definitely cardio. I mean, you have to have cardio. I mean, your cardiovascular system is, as soon as we hit menopause, we become like men. Estrogen is cardioprotective. And as your
Yes.
estrogen declines, your risk of cardiovascular disease becomes the same as a male.
Yeah. Okay, so that deals on the physical, and I think it's a good emphasis, because I'm not sure in the general female population there's this view like, I really need to be. Look, you have the subgroups that are physically active and doing this stuff, but I'm not sure what the general thought process is. I've got to be really as best or as fit as I can be from a cardio and say muscle strength perspective before I go into menopause. That being the focus.
The other important thing I tell patients, as you age, you have to decrease your fall risk. And the only way you're going to decrease your fall risk is to have good core. And, you need good core, you need balance. The only way you improve your balance is with resistance, muscle mass. You have to be able to correct yourself when you're on uneven surfaces, as you age, so that you don't fall. You don't want to fall and fracture when you're in your
Sure.
70s and 80s. And you will only do that by doing good exercise. And when you're older, things like Pilates, core, balance, all of those things.
So let's stay in the premenopausal phase, just to give some medical indicators or advice to what type of screenings should women in the age range, let's say 30 and 40s, premenopausal, if we can say that, 20s, 30s, and 40s, what type of screening should women in these age categories be doing? And you can break them up in those specific ones if you'd like to. What should
Yeah.
they be focusing on?
So in your reproductive age group, so the thing that affects women the most is cancer prevention. Okay, and one of those things, obviously, I don't know if you know that more women die of cervical cancer than from breast cancer. So breast cancer is the commonest cancer that affects women. Cervical cancer is the second commonest cancer, but more women die from cervical cancer than women who die from breast cancer. And
We're talking about South African stats, right? Across the
I'm talking
population?
about worldwide.
Okay.
Worldwide. When you get a breast cancer, you're more likely to survive. When you get a cervical cancer, if you get it late, you're more likely to not survive it. So, and certainly South African statistics are appalling. But, cervical smearing or screening is key. And we no longer do a pap smear. We actually test for HPV. So primary HPV testing from the age of 25 is what we all should be doing. And when do you stop that? The consensus is not quite clear, but probably 65 to 70, you can stop cervical screening, provided you've had normal screens.
Right. So when you say cervical screening, I think a lot of women know pap smear. Are they still doing pap smears and HPVs?
You do it just like a pap smear. So you take, and you can even screen yourself. We can talk about that. But a pap smear is when you actually put a brush in the cervix and you twirl it around, and those cells go off to the pathologist to have a look at. But we know that that is a human who looks at it. And with a pap smear, there's always human error. And a pap smear can be wrong 40% of the time. Do you know that?
Wow.
Whereas HPV causes an abnormal pap smear. And so if you are HPV negative, you will not have an abnormal pap smear. And HPV is a yes or no question. So they look for the DNA of high-risk HPV. And if you are HPV negative, you do not need another cervical screen. And that is done on the test, the same as a pap smear. And if it comes back positive, then they look at the cells.
Sure.
And then it makes the pathologist look harder. You know, if the pathologist knows there's HPV, they'll look harder. So the new way of screening is with an HPV test on the
And
pap
is that,
smear.
are you suggesting a woman do this annually?
No. If you are HPV negative, you do not need another screen for at least 3 years. So if you have a look on the major medical aid now, they will say you only need an HPV screening every 3 years.
Okay.
But you can self-test if you don't want to go to the gynecologist.
How does that work?
So you put a tampon, you get self-testing kits, you put a swab or a tampon in your vagina, it goes into a bottle, it goes to the laboratory, and they test for HPV. And then, so, you know, there is a move in the world to possibly self-test. So that's number one. Number two, obviously breast screening, and that should begin at the age of 40. You would, unless you have a family history. If you have a family history, you need to be screened 10 years before the youngest person. And then the other thing, obviously, that you should start doing now is whether you should have a colonoscopy or whether you should send your stool for what's called a FIT test. And a FIT test is like an immunotest for human blood. So that is for colon cancer, because colon cancer is becoming more and more common now. So those are the screenings. And then when you hit menopause, that's when you start on the bone density screening.
Fine, and we'll get there. Okay, so I'll be saying, and I think that's very valuable, cancer is sort of one of the biggest risks for women pre-menopause, and it's cervical, breast, and colon, right, as big ones to actually do the screening for.
Sorry, Avron. Can I just ask a quick question for Trudy? I'm just curious about a statistic. Trudy, in regards to HPV, how common is HPV? If you know offhand, like, I mean, how many,
Sure.
is it something that women are testing positive for frequently, or is it something that's rare?
So human papillomavirus is very common.
Okay.
So 80% of us will have a high-risk HPV sometime in our vagina, particularly if we are sexually active, even with one partner. And the younger you are, the higher your risk of HPV. But most of us will get rid of HPV. So we mustn't be afraid if we have a high-risk HPV. Most of us will get rid of it. But the two that we're very afraid of, now possibly three, is HPV type 16 and 18, because they're quite elusive HPVs. So that's why we like to vaccinate adolescents, boys and girls, because we're all going to get HPV, whether we like it or not. It's just whether we get rid of it. And the two things that are the most abominable things is smoking and vaping, because smoking and vaping prevents you from getting rid of HPV. And vaping's even worse than smoking, because nicotine levels are much higher in vapors, because vapors sit there all day. So their nicotine levels are much higher than a cigarette smoker, because nicotine is the problem. It inhibits your ability to get rid of viruses. It paralyzes special cells called Langerhans cells, which are important to get rid of viruses.
I think that's new information for me. Sorry, go for it, Mark.
Yeah, just two more questions. And again, I'm sorry that I just slightly off topic, but I want to just grasp your expertise as much as possible. So I've seen a huge increase in PCOS in women that, you know, come to the gym and that I deal with on a fitness level. Is something like PCOS becoming more prominent? And if so, why is it becoming more prominent? Maybe I'm wrong. Maybe it's just something that has been a thing for forever.
So
I
is
think it's a great
PCOS
question. Before Trudy answers, Trudy, just for our listeners, will you just just explain what PCOS is?
So
Um,
PCOS is polycystic ovarian syndrome. That's what the word means. And PCOS, it has strict criteria for diagnosis. So often people say you've got PCOS, but do they truly? They might have polycystic ovaries, but not the syndrome. So the syndrome is categorized by hairiness, acne, irregular periods, and weight gain with polycystic ovaries. You need to have at least 3 of those things, or fertility issues. So PCOS is also possibly weight, lifestyle, obesity related. You know, what came first? Did the polycystic ovary come before the weight gain, or did the weight gain create the polycystic ovaries? It's a very difficult dynamic.
Okay,
mm,
cool. And then the last question, which is even further off, but it's just touching on what you mentioned about vaping and the ability for your body to fight off viruses. What is because again, I mean, it is the absolute new craze. We deal with it in the gyms all the time. All of the young people that we see in the gyms are vaping. I mean, anyone between the ages of 18 and 25, if not older, are vaping. What is the, let's say, recovery period that your body can start fighting these things if you were to stop?
I don't think we have, I don't know, Aaron, do you know the answer to that? I don't think we have the exact data on that, but I can tell you the addiction rate is higher on the vaping. It's extremely difficult for people to stop vaping.
mm.
It's really hard. And unfortunately, you know, vaping is not as antisocial as smoking. And that's
Yeah.
why vaping is a big problem. We're doing a trial at the moment called Serve SA, Cervix, Serve SA.
Mhm.
And we're looking at all the patients that are referred to us. And we're looking at the incidence of vaping in women with HPV, and it's extremely high.
You
Okay,
said,
cool.
I just want to
Thank you.
go before we talk about supplements. Thanks, Mark. Great questions. You spoke about it occurs in men as well, right? Trudy?
Yes.
Okay, so
Human
it's not,
papillomavirus.
yes,
So HPV does very little to men, except it can cause throat cancer and anal cancer.
right.
Whereas HPV in women causes cervical, anal, and throat cancer, but vulva and vaginal cancer. Penile
Fine.
cancer in men as well, but penile cancer, thank goodness, is rare. And it's rare because the skin comes off the penis desquamates. Do you understand? Whereas the cervix
Yes.
is a thing in the deep, dark vagina that nobody wants to talk about. So, you know, I feel sorry for the cervix.
Yeah. Okay, fine. So that's fine on the screenings. You said cancer is probably one of the biggest risk areas in premenopausal women. We've spoken a bit about exercise. Supplements, particularly around bone health in the premenopausal area. I'm interested to know what your thoughts are. Probably Mark's got also a few ideas around what he sees women using. But in terms of supplements, if you had to advise women what they should be supplementing with, if anything at all, in the premenopausal health phase, what would you suggest?
So I would say that if you ate healthily, you would never need to supplement anything. So, I mean, a healthy lifestyle with good healthy eating, with, 5 colored vegetables. In fact, I went to a very interesting talk by the gastroenterologist on gut health and the biome. And I don't
Mm.
know, sort of multicolored vegetables, lots of them, not processed food, no carbohydrates, less alcohol, all of those things are really important from a bone health. I mean, you can download a calcium calculator and it'll tell you whether you're having adequate calcium intake. So for bone health, probably calcium, but the problem is if you use too much calcium, for instance, if you're using 1,000 milligrams a day of calcium, you lay down plaque in your heart and it increases your risk of cardiovascular disease. So, you should never be taking more than 500 milligrams of calcium per day from a supplement perspective. I'm not a major supplement fan. I think you should be eating properly rather than supplementing. And you should be staying away from processed food, high, carbohydrates, etc. But yes, calcium, and then vitamin D deficiency is a big problem because people don't go in the sun anymore. And if you had 5 minutes of midday sun, you would probably get enough vitamin D. But vitamin D supplementation definitely and possibly should be measured.
Right. So if you're adequate in the calcium, vitamin D, you would suggest no supplementation. Otherwise, potentially looking at those. Mike, what do you see on your side? Do you see any particular supplements that women in the pre-menopausal phase are taking?
Yeah, so I completely agree with Trudy and exactly what she said. Calcium and vitamin D would be the only supplements that I would recognize to aid and assist. I would, and again, saying that if the perfect diet is in place, but unfortunately, as we know, healthy eating is the most expensive form of eating, which is hilarious, but it's the most. So if you look at the average household, it isn't in the average South African's budget to live a processed food-free life. Just really isn't. So if you have to supplement, as Dr. Trudy said, 500 milligrams of calcium and some vitamin D, I think it's important for women that are going into menopause or anyone to stay hydrated. I have read studies that hydration and reduced sugars does reduce hot flushes in some cases. Again, I'm not sure how accurate that is, but it's what I've read. About 1.2 grams to 2 grams of protein per kg of body weight is obviously good to keep muscle mass up and obviously help bone density. I would say the only supplement that I would genuinely recommend is something like a whey protein. That's a good source of protein and a healthy source of protein without added sugars, etc. If you're struggling to get enough protein, because what I've seen with women is the struggle to eat protein seems to be a lot higher than for men. There's this whole drive for men to eat protein and grow muscle and all that kind of stuff. And when you look at social media and everything that's portrayed for women, it's eat as little as possible, have a salad, and all that kind of stuff. It's like, well, that's not the most important thing if you're looking for your health. So I think that a sustainable source of protein that's taken in adequately through the course of the week and not abused is a good thing for women to consider, just in terms to get those protein markers, which is obviously a lot lower than men because we carry a lot more muscle mass. So to maintain and grow, men require more protein. So I don't believe, having a small amount of whey protein every day will definitely be a good supplement if you can't get the natural sources in, of course. So yeah, that's my recommendation.
Fine. Thank you. Okay, guys. So I think pre-menopause, hopefully we've answered a lot of questions. I'm sure there are a lot more in this topic and go on for a long time, but I think let's move into the menopause and post-menopausal phase, right? And Trudy, moving into this phase, just to explain to our podcast listeners, what's the biggest hormonal and physical changes that women now start to experience?
So the important thing to understand is as you transition is that your hormones start swinging wildly. Okay, so your estrogen can go from super high and plummet right down. So, in the perimenopausal phase, up until your last menstrual period, many women go and they measure their estrogen and then it's really high. And then they get given a whole clump of stuff to try and bring down their estrogen. That is a normal process, unfortunately, of the perimenopause, is that you make too much estrogen and too little progesterone. And that's why your periods start becoming irregular. And then your estrogen drops and you start getting night sweats and hot flushes. Not everybody does, but a lot of women do. You get mood changes, brain fog, decreased libido, anxiety, depression, funny sensations of crawling underneath the skin. You can get palpitations. You can get joint pain. There are about 37 symptoms of the menopause, perimenopause. So it really does make it difficult. the important thing is that you'll get a change in your menstrual cycle. You'll start missing periods, or your periods become longer, or they become shorter. The other thing to stress is that if your period goes on and on and on for 3 weeks or 4 weeks, you need to seek help and you need to see somebody. So that is not a good thing. But yes, it can alter by sort of 7 days either way. And those things are all mostly estrogen related. Progesterone is there to protect your uterus, and estrogen is what gives you most of these symptoms. And particularly early in the menopause, after your last menstrual period, they can be quite profound, those symptoms.
Mm.
So,
So,
yeah.
okay. Yeah, I mean, it sounds it sounds quite probably frightening for a woman who has moved into that period. These changes are going to happen. But, okay, so we have a woman who's approaching that. The symptoms are starting to develop. What must she do? Is there any treatment? When should she start treatment? Shouldn't she?
The first thing you need to do is lifestyle modification. So you need to cut back on alcohol. Exercising is very important. In fact, what they've shown is exercise decreases the amount of flushing. Alcohol increases flushing. Caffeine increases flushing. Things like yellow cheeses, spicy foods, they all increase flushing and menopausal symptoms. So, you want to improve your hydration, cut out the caffeine, lower your alcohol intake, all the normal things that we should be doing in any case, exercising, etc. And then, when these symptoms, and if they do become intolerable, then you need to seek help. And, if you've got no contraindication to the use of hormone treatment, then we have to appreciate that unfortunately is what's going to make your life better.
Where are we? And I've had a lot of questions around this, and in the literature, where are we sitting currently in the medical world in terms of hormone replacement therapy? Is it something that women should be scared of, or they should be doing, or? And I know there have been swings and rounds on this, and swings and roundabouts on this issue.
So let's discuss what hormones are good for. Okay, and then we'll discuss what they're bad for. So there is what we call a window of opportunity. So if you institute hormone, we don't call it hormone replacement therapy anymore, because you can't replace what hormones you naturally have. We call it hormone treatment. And if you have no symptoms, you shouldn't be taking medication that you don't require. So, if you are symptomatic and you need help, so what is hormone treatment good for? Hormone treatment is good for your bones. There's no doubt about it. It decreases your fracture risk. It is good for your brain, particularly in the early perimenopausal stage. So that's in the window of opportunity. So if you didn't take hormone replacement therapy and now you want to institute it after 60, we know, in fact, it increases Alzheimer's and senile dementia. So there's that, what we call a window of opportunity. If you take it early in your menopause, it decreases your cardiovascular risk from a heart attack perspective, because it prevents you from laying down plaques. Once you've laid down plaques, then it can increase your plaque formation. But if you take it in the early perimenopause, menopause, it decreases plaque formation. Obviously, libido. If you have vaginal dryness with atrophy and stress incontinence, urinary incontinence, with painful intercourse, you're not going to want to have sex. Your libido is going to be down because it's too painful. So even the use of vaginal estrogen in those women alone can improve their lives. So there are good things about hormone treatment. It helps your brain, your skin, your muscle mass, all of those things. But there is definitely a slight increase in breast cancer risk long-term if you use hormone treatment. But that's why women on hormone treatment should have mammograms. And in fact, all women should have mammograms, but a woman on hormone treatment is more likely to go for a mammogram than somebody who's not.
From what you're saying to me, and we can get, is that it sounds that women start hormone treatment, that's used that term, too late. And it's one thing you're saying, well, you should only be starting hormone treatment if you're having symptoms, but some of those protective factors that you're outlining, could they not be sort of an argument to saying, well, whether you have symptoms or not, you should actually start hormone treatment quite early when you start developing these symptoms?
If you have symptoms, then you need to see if you should consider it. Yes, certainly. But you have to have a baseline mammogram before you start any form of hormone treatment. And, you need to take a family history. You can't give hormone treatment to everybody. So people with clotting problems can't go, you have to be cautious. Women who have a breast cancer or a strong family history, you need to take that into consideration. So women with autoimmune disorders like lupus and clotting things, you can't use hormone treatment. So, it's not something one size fits all, but it is something that you need to consider. Obviously, there are other drugs you can take for instance, if you have hot flushes and you don't want to take hormone treatment, you can consider an antidepressant called an SSRI, and that acts on the thermoregulatory system in your brain and decreases flushing. So there are alternatives. If you have low bone density, you can be put onto what's called a bisphosphonate, which is a drug for bones alone. If you have vaginal dryness, unfortunately, there are no good moisturizers, but there are vaginal estrogen. Even in breast cancer survivors, we use vaginal estrogen because it's exceptionally low dose without increasing your blood levels of estrogen.
And I think what we're saying in the show, because obviously there's a exercise and fitness slant as well here, that in terms of your bone health, it should be a strong consideration, right?
In hormone treatment
Yes.
or exercise. Listen, I think
Both.
you must exercise, and it must be weight-bearing exercise. It has to be strength and weight-bearing exercise. So, for instance, and Mike can, contradict me on this. Like, for instance, swimming is not good on bones. And a going nowhere bike is not good on bones. But if you're off-road mountain biking, that's better from a bone perspective. You need strength and weight training. Walking
Well, yeah,
is
I think
actually
impact. I think impact and resistance is probably what you need. So, as you said, if you're sitting on a bike and there's absolutely no impact happening versus being on an off-road bike where your muscles have to activate to take impact, to take small bumps, etc. That's bone density increasing, it's muscle mass increasing. So definitely, there are cardio activities that you can do that also help with bone density and muscle
So,
mass.
Mark, that ties into one question I have here, which is, what's the one, and maybe you can answer this, what's the one non-negotiable exercise after menopause? Would you call it, say, impact?
I think that's a bit of an impossible question in terms of it depends on the goal, Avron, I guess. So if you're talking about resistance, then there's no such thing as a one movement fits all. If we're looking to build muscle mass holistically, then we're looking at compound resistant movements in the gym for all facets of the body. So we're doing a squat, whatever that squat looks like, depending on the person. If they're a stronger, more active person coming from an active lifestyle, then a free weight squat. If they're not, then a leg press, which is much more controlled and much easier to do. Same thing with a bench press. If a lady has come from a strong active background and feels like she can handle free weights, then a bench press where you're stabilizing is going to be more beneficial. But for the most part, because of the environment we live in and because females are often shunned away from resistance training through social media and those kind of things, a big portion of them never really grasp onto that. So starting later in life trying to do a free weight exercise is probably, in my opinion, a little bit more dangerous than rather starting with machine-based resistance training where you can get comfortable and strong. And then the ultimate goal should always be doing free weighted movements because it requires stabilization. And as Dr. Trudy said, you don't want to fall as you get older and being able to move weight that you have to use small stabilizer muscles within the body is definitely going to decrease your risk of having bad falls later on in life. So that would be my suggestion. No one size fits all exercise, but starting within the scope of what you're able to do, you either start on cable operated machines where it's very, very safe and you move on to free weight exercises. Or if you have a history in training, then my suggestion would always be compound exercises that require resistance on a free weight.
Right.
I would say they must get moving, whatever
Yes.
it takes.
Yeah,
I
100%.
mean, you have to get moving.
And Mark, do you see an issue with this, with in terms of women post-menopause getting moving, coming into the gym? And let me ask you this: in your gyms and wellness, do you see more women in their pre-menopausal or post-menopausal phase?
I mean, I think it's very skewed to premenopausal. But again, that's not to say that it's that way for any reason other than we live in a society that rewards people for aesthetically looking good. So it's driven for younger females and younger men to be in the gym. One, it's easier for you to do because you're fit and you can wake up early in the morning and you feel great and you can drink the whole weekend and go to gym on a Monday and still feel great. Whereas I think as you get older, it kind of that whole recovery period really starts playing a factor. So I think that we definitely see a lot younger women and younger men in the gym as a standard. And I think that we see that women are way more consistent once they get motivated. I've always said that a determined woman is a lot scarier than a determined man, because when women kind of get onto the fitness journey and stuff like that, they don't fall off as easily as men do. So I think that if women can make it a habit in their day to day and make the right habits early on, they will see that fitness journey out throughout their life. You see a lot more fall off in terms of male fitness as they get older versus female fitness. And I think the statistics are pretty hectic on that. Women that have been training from the age of like 22 or 23 have I think it's like a 67% lower fall off risk once they reach 50 years old versus men.
Right.
And again, the numbers might be different, so don't take that stat on like baseline, because there's a lot more men training naturally on the planet than there are women, so the stat is slightly skewed. But I think that from what I've seen in the gym environment, if women can get into it young and make that consistency, they tend to just do a lot better as they get into older age. And yeah, they just seem to be a lot stronger and make it through that menopausal period quite easy. But the women that are coming in with low bone density, as Dr. Trudy said, it's a very, very hard road, because already females struggle with just early on in life with the fluctuations in hormones, going from like cycles within the month where there's low energy, high energy, and trying to navigate that, to almost going to a point where it's mostly low energy and low recovery. So we already see where the struggle comes in certain periods of the month. Now it's something you have to deal with almost on a daily, weekly basis. So it is a lot harder if you don't have a baseline of fitness to get into it post-menopausal.
But menopausal women who exercise sleep better as well.
Yes.
So,
Well, I wanted to
also
move into
better.
talk a bit about the mental side, mental health side. Obviously, women struggling with weight gain, mood swings, and sleep. Obviously, exercise, and what I'm hearing from Mark and Trudy from you, obviously, exercise is a key part of that, right? And managing that, both from just the exercise direct physical effects, but also from, I suppose, social connection and feeling well.
So what's also interesting from as we age as women, from a senile dementia and Alzheimer's perspective, is that women who exercise, and particularly women who exercise with friends, if they walk and talk, social interaction, is that your senile dementia and Alzheimer's is much less. So
Wow.
you need that interaction. I mean, it really makes my heart warm when you see families exercising, from
Yes.
young kids. And so, because that's going to be a chain reaction, that's going to make your kids exercise when they're older. And then particularly if you continue into your postmenopausal, and it's not easy. I mean, as a working woman, it's not easy. I'm on the road at 5:30 in the morning.
Exactly.
I go to Pilates at 6 or whatever, but you can make it happen.
Sure. Let's go into some myth busting as we and clear up some common misconceptions. So, Trudy, what would you say sort of is like the one big misconception that women have about menopause that you potentially would like to correct?
I think the one myth is that every single woman who takes HRT is going to get a breast cancer, and that's not true.
Yes.
Women who don't take HRT also get breast cancer. Women have breasts. We're the most at risk of breast cancer. And in fact, what they've shown is obesity alone increases your risk of breast cancer.
So it should be a serious consideration, right?
Yeah.
Sorry, Avron, I would really like Trudy to bust a myth for me, because I feel like I may never get this opportunity again to ask this, and it's something that
Yes,
I've actually
go
sat
ahead.
with for probably about 15 years. So, Trudy, I spent a lot of time in Asia when I was younger, and I had many conversations around fitness with older Asian ladies, because they were part of where I worked and where I trained, and a lot of them did not have a word for menopause. And when I did a bit of research back then, there was a lot of data indicating that because their diets are rich in estrogen enriching foods like soy, they got menopause later in life. I don't know how true that is, and I've always wondered, like, is there any kind of basis to this, or is it just a myth?
There is data. There is data. So I can tell you that Black African women, their menopause is slightly earlier, and Asian women's menopause is later. Different groups experience different symptoms. Asian women have less hot flushes because of their diet, which is higher in soy. So tofu, etc.,
And is that
has
because we were
estrogen.
going to go on to diet, and I wanted to ask you, which just post menopause, sort of what are the recommendations in diet? Is there any significant points that you'd like to talk about? And is tofu one of them?
Well, women who have diets that protein is a big problem for older women. They often don't eat enough, and they get sarcopenia, so they lose muscle mass. Again, it needs to be a mixed, varied diet. But some women eat way too much soya, and then when you have too much soy, you can actually have too much estrogen. So, it is a balanced diet that you need.
So to answer Mark's question, would you say soy is helpful post menopause?
I would say that I don't know that we have good data on that.
Okay.
Trudy, sorry, would you maybe say that there's more beneficial information towards a varied diet that maybe contains soy premenopausal that might push that menopausal date out? Because, I mean, again, that's based on the data you gave me now, saying that, and again, I'm sure that that it's not necessarily just down to that Asian women typically go through it later, but there's got to be a contributing factor, and I don't think that starting to eat soy once you've gone through menopause is going to make much of a difference versus maybe having a diet that has a slight amount of soy in it while you're younger. Maybe is there any validity to that?
We don't have data on that. I mean, it's also genetic. So, unfortunately, they come from the same genetic background. So, it's also a genetic thing. But I think also what we have realized is that the more we talk about it, the less of a taboo it is. So, the biggest problem I have with a lot of women is they're like, oh my God, my mother, nobody told me this was going to happen to me. This is like tragic,
Yes.
So I think we need to talk about it.
Yeah. And I think that's part of the podcast and the show is education. Let's talk about it. One other quick question that's come. Best supplement for postmenopausal women. Trudy, what would you suggest on that one? We spoke premenopause, but postmenopause.
I think exactly the same. There's a little bit of work on calcium with K2, so with, together, improves the absorption. But you have to be careful with too much calcium and constipation in the elderly, and diverticulosis. So, yeah.
It's been fascinating. I definitely think from what we brought out, we can redo this and focus on particular areas. And there's just so much information. But certainly from my side, I found it fascinating and really educational, Trudy, and Mike, your input as well. And maybe just from each of you, if just to finish off our podcast, what's one key message that you'd like to give to women approaching or going through menopause? Trudy, maybe we can start with you, and then Mike will go to you.
So my key message is, if you are symptomatic and struggling, seek help. But I think we need to also discuss that your help needs to be within the realm of registered, licensed medication. We can have a whole discussion on unregistered, unlicensed medication, and to have a healthy lifestyle.
Thank you. Mark?
I mean, again, I hate to comment on things that I'm really not in the field of, and I think Trudy said it best, and I don't have much to add on that. I think, again, one thing that's been prevalent in this whole discussion is that whatever topic we cover, it always seems to be better if someone is training and eating healthy. Like there's no way around that. And I think if there's a takeaway on this, is start younger than older, because at the end of the day, there is no substitute for a well-aged process in your life. Once you get sick, you'd give everything back to be healthy again. And unfortunately, if you don't make those decisions early on in your life, then it is almost inevitable that you will get sick and that you will struggle later on in your life. And it's one of those things that we don't think about while we're here, while we're young and while we can move. And then, I look at myself as a prime example. I was terrible when I was younger at stretching, and now being 36, I'm definitely not old, but I struggle because I don't have flexibility that I should have had. And I could have corrected that when I was younger, and it's much harder to correct now. So my advice to everyone is, get the little things right when you're younger and actually enjoy the aging process, because you are a lot more capable and you can be a lot more capable and active much late into your years in the current landscape that is fitness and everything that we have on hand. So yeah, just to echo Trudy, I think fitness, exercise, and good eating from as young as possible is the key takeaway.
And as Trudy said, keep moving. Thanks, guys. It's been a fascinating Let's Talk on Women's Health. Dr. Smith, Dr. Trudy, thank you for your time and incredible insights. It's been great to have you on the show, and we really appreciate it. And to Mark, our fitness and health and gym expert, of course, thank you for your amazing insights. And to everyone who's joined, thank you for being part of this conversation. We hope tonight has helped you empower and has helped empower women to take charge of their health at every stage of their life. Have a good evening, everyone, and look forward to the next Let's Talk Health episode. Good night.
Thanks, Avron. Thanks, Trudy.
Let's talk.